According to the DSM-5, the physiological response to anxiety is more often associated with muscle tension and vigilance in preparation for future danger with cautious or avoidant behaviors. Fear, on the other hand, is a reaction to a specific danger, and more often the body reacts with surges of autonomic arousal necessary for fight or flight, thoughts of immediate danger, and escape behaviors. Another important distinction between anxiety and fear is that anxiety affects us at a deeper level than fear does. Anxiety invades the central core of the personality. It erodes the individual feelings of self-esteem and personal worth that contribute to a sense of fully feeling human. Normal anxiety is a healthy life force that is necessary for survival. It provides the energy needed to carry out the tasks involved in living and striving toward goals. Anxiety motivates people to make and survive change. It prompts constructive behaviors such as studying for an exam, being on time for a job interview, preparing for a presentation, and working towards a promotion. Acute anxiety is also referred to as state anxiety. Acute anxiety is precipitated by an imminent loss or change that threatens an individual's sense of security. Acute anxiety is a normal and expected response to stress. For example, many entertainers experience acute anxiety before live concerts or theater performances, and students may experience acute anxiety before an exam. Patients preparing for surgery often experience acute anxiety due to the fear of the unknown. The death of a loved one can stimulate acute anxiety when there is a great disruption in the life of the bereaved person. In general, crisis involves the experience of acute anxiety. The table 11-2 and 11-3 look at levels of anxiety and how the nurse can intervene. Healthy defense mechanisms useful in overcoming stressful or anxiety-provoking situations include altruism, which is an act to promote someone else's welfare, even at risk or cost to ourselves. Some neuroscientists believe that people who have altruistic behaviors activate their brains in the limbic system. The limbic system is the region that signal pleasure and reward, much like if we eat chocolate or get a natural high from doing something adventurous like skydiving or bungee jumping. Another healthy defense mechanism is sublimation. Sublimation is a mature type of defense mechanism where socially unacceptable impulses or idealizations are unconsciously transformed into socially acceptable actions or behaviors, possibly resulting in a long-term conversion of the initial impulse. If people have aggressive behaviors or tendencies, they may benefit from playing rough contact sports such as football to release that tension that they have. Suppression is the conscious denial of a disturbing situation or feeling. For example, a person cannot focus on any other tasks, no matter how important, until another task is completed. Humor makes life easier. An individual may deal with emotional conflicts or stressors by emphasizing the amusing or ironic aspects of the conflict or stressor through humor. Making light of a situation may make the stress level ease for everyone involved. You'll see this like with a family member joking and remembering the good times with a patient who is dying. Intermediate defense mechanisms can go either way. There will be occasions that the defense mechanism relieves the situation, but may actually make the situation worse in other aspects. Repression is the exclusion of unpleasant or unwanted experiences, emotions, or ideas from conscious awareness. One example of repression is when a woman is married to an abusive man, and if the woman is able to remove herself from that situation, she may forget all of the bad things related to her relationship. This may be good so that she can continue living a healthy life afterward, or she may return to the man forgetting all of the horrible things that have happened. Repression is considered the cornerstone of the defense mechanisms and is the first line of psychological defense against anxiety. Transfer of emotions associated with a particular person, object, or situation to another person, object, or situation that is non-threatening is called displacement. The frequently cited example in which the boss yells at the man yells at his wife, the wife yells at the child, and then the child kicks the cat, demonstrates excessive use of displaced hostility. The use of displacement is common but not always adaptive. Spouse, child, and elder abuse are often cases of displaced hostility. Reaction formation, also called overcompensation, is a mechanism that occurs when the person displays the opposite emotions of what they are really feeling. An example of this situation would be if a woman states to her friends, "I just can't wait to move back to Michigan," but what she's really saying is, "I'm going to be heartbroken when I have to leave my friends. How will I ever make it without them?" Transforming anxiety on an unconscious level into a physical symptom that has no organic cause is a form of somatization. Often symptom functions as an attention seeker or an excuse. One display of somatization is when a person suffering from depression complains of stomach pains constantly, yet there are no symptoms or underlying causes, proving that the stomach pain is triggered by something. Undoing is the performance of an action that is intended to negate a previous action or communication. A common behavioral example of undoing is when a spouse brings flowers home to his wife after an argument or after having an affair. This can be viewed as cleansing one's self of an act or thought perceived as unacceptable. Rationalization consists of justifying illogical or unreasonable ideas, actions, or feelings by developing acceptable explanations that satisfy the teller as well as the listener. One might say, "I can't lose weight because I'm just too busy to exercise." The person is making excuses even if she doesn't have a lot of time to exercise, or other healthy choices can be made to assist in losing weight. These type of excuses are heard a lot by nurses and physicians. Immature defense mechanisms include ways that people deal with stressful situations that may be harmful to themselves or to others. A passive-aggressive individual deals with emotional conflict or stressors by indirectly and unassertively expressing aggression toward others. On the surface, there is an appearance of compliance that masks covert resistance, resentment, and hostility. The aggression towards others is expressed through procrastination, failure, inefficiency, passivity, and illnesses that affect others more than themselves. One example of passive-aggressive behavior is when a person gives another the silent treatment. You know that the person is upset with you, but they will not really communicate what the situation is. Acting out behaviors are a destructive coping style. In acting out, an individual addresses emotional conflicts or stressors by actions rather than reflections or feelings. For example, a person may lash out in anger verbally or physically to distract the self from threatening thoughts or feelings. The verbal or physical expression of anger can make a person feel temporarily helpless or vulnerable. By lashing out at others, an individual can transfer the focus from personal doubts and insecurities to some other person or object. Dissociation is a disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. Not being able to remember all details of a traumatic event is one way of separating the person from the event when it's too overwhelming to deal with. Devaluation occurs when an emotional conflict or stressors are handled by attributing negative qualities to self or others. When devaluing others, the individual then appears to be good by contrast. Sometimes coworkers may do this when a promotion for an employee is coming available. Idealization, emotional conflicts or stressors are addressed by attributing exaggerated positive qualities to others. Idealization is an important aspect of development of the self. Children who grow up with parents they can respect and idolize develop healthy standards of conduct and morality. When people idolize and overvalue a person in a new relationship, they are sure to be disappointed when the object of the idealization turns out to be human. This leads to a great deal of disappointment and painful lowering of self-esteem. Such individuals may then devalue and reject the object of their affection to protect their own self-esteem. This pattern can be repeated over and over again on a job, in friendships, and in intimate relationships, and even in marriage. Splitting is the inability to integrate the positive and negative qualities of oneself or others into a cohesive image. Aspects of the self and of others tend to alternate between positive poles. For example, either good, loving, worthy, or nurturing, or it could be bad, hateful, destructive, rejecting, and worthless. Use of this defense mechanism is prevalent in personality disorders, especially in people who have borderline components. Projection is the hallmark of blaming, scapegoating, prejudicial thinking, and stigmatization. They have excuses as to why they act a certain way. One example of this may be, I'm rude to others because people are rude to me. This is not an excuse for one to act this way. Others don't control my actions or behaviors. And lastly, denial. Denial involves escaping unpleasant realities by ignoring their existence. One good example of denial is a man knows that his wife has passed away, but continues to set the dinner table for her and keeps her things the way she had them before her death. Or when a person who has been told that they have a sexually transmitted disease continues to have sexual encounters with multiple partners because they don't believe that they actually have this disease. Numerous studies have shown that anxiety disorders tend to run in families. Twin and family studies show that panic disorder has a heritability of approximately 40%. Learning theories provide another view. Behavioral psychologists conceptualize anxiety as a learned response that can be unlearned. Some individuals may learn to be anxious from the modeling provided by parents or peers. For example, a mother who is fearful of thunder and lightning, who hides in the closet during storms, may transmit her anxiety to her children, who continue to adopt her behavior even into adult life. Such individuals can unlearn this behavior by observing others who react normally to a storm. Cognitive theorists believe that anxiety disorders are a result of distortions in an individual's thinking and perceiving. Because individuals with such distortions believe that any mistake they make will have catastrophic results, they experience acute anxiety. Brain scans taken before and after cognitive therapy treatment support that this hypothesis is accurate, that learning to reframe one's thinking can literally change the chemistry and function of the brain. Cultural considerations related to panic disorders present in various ways. Because of this, it is important for clinicians to be aware of relevant contextual information stemming from a patient's culture, race, ethnicity, religion, or geographical origin. For example, uncontrollable crying and headaches are symptoms of panic attacks in some cultures, while difficulty breathing may be the primary symptom in another culture. Interestingly, the incidence of anxiety disorders seem to vary among culture and countries. Anxiety disorders also vary among immigrants from generation to generation. One must be aware of the cultural norm before hastily making a diagnosis, like labeling ritualistic behavior as an obsessive-compulsive disorder.
So let's talk about the limbic system. What is the limbic system? Well, it's a set of structures in the brain, and many of those structures play an important role in regulating emotion. Now, something that gets kind of confusing when you talk about the limbic system is that experts can't actually agree on what structures make up the entire limbic system. So for our purposes, I'm going to address some of the most important structures and ones that everyone pretty much agrees are part of the limbic system. Now, before I get going into the nitty-gritty, so to speak, I want to give you a quick overview of what structures we're going to talk about. And the way I remember these structures is through this little cartoon here. This is a hippopotamus, and he's wearing a hat. Now, why is this hippopotamus wearing the stylish hat? Well, this is my way of remembering the four most important components of the limbic system when it comes to emotion. So we see a hippopotamus here. I'll write hippo. And we see him wearing a hat. I'll write hat. Now, for this to be a mnemonic, it has to be something useful. And the reason I think of this is these are the four main structures in the limbic system when it comes to emotion. So HAT stands for hypothalamus, A for amygdala, T for thalamus, and hippo, short for hippocampus. And these happen to be the four structures that I'd like to talk about. So let's get to a little more complicated diagram. And what you see here is my best attempt at drawing the limbic system. Now, limbic system structures sit on top of the brainstem, and this is the brainstem. And you can imagine this as the very bottom of your brain, and here's the spinal cord coming out of it. And the spinal cord goes all the way down your back to about your tailbone. Now, the limbic system are these structures up here that are drawn in bright colors. Now, to orient you to this diagram, this is what you would see if you pulled off like the top part of your brain, which is called the cortex. And it's facing in this direction. In other words, while this isn't anatomically correct, let's say your eyes are here, your nose is here, and your mouth is here. Again, this is not anatomically correct, but this you can see is the front, and this is the back. So I kind of drew it at an angle so you can kind of get a 3D idea. So let's remove this and go back to talking about the anatomical structures. So this blue thing here, this is called a thalamus. And you actually have two of these, one here and one on the other side. So your thalamus functions as like a sensory relay station, meaning the things that you see, hear, taste, touch, all these senses you have come through your nerves and ultimately end up in your thalamus. And the thalamus directs these senses into the appropriate areas in the cortex, as well as other areas of the brain. And I mention this in terms of an emotion lecture because emotions are very contingent on the things that you see, the things that you touch and hear. Now you may have noticed there's one sense that I didn't mention, and that's the sense of smell. And the sense of smell actually is the only sense that you have that actually bypasses this thalamus. And instead, it has its own private relay station that when it comes from the nose, it goes to a certain area in the brain. And that area of the brain actually has to be very close to other areas that regulate emotion, which explains why sometimes certain scents can evoke very powerful memories and bring you back to a certain moment in time. But in terms of emotion, I mentioned thalamus because of how the senses play an important role in your emotions. Now you see here there's these two purple structures, and this is known as an amygdala. Amygdala. Now the amygdala is sometimes called the aggression center, and experiments have actually shown that if you stimulate the amygdala, you can produce feelings of anger and violence, as well as fear and anxiety. I'm going to put stimulate and represent it as a dark green plus sign. So if you stimulate the amygdala, it invokes feelings of anger, violence, fear, and anxiety. On the other hand, if you've destroyed your amygdala, and I'll represent destruction as a red negative sign, if you destroy the amygdala, it can cause a very mellowing effect. All right, mellow. And this mellowing effect, in the context of a destroyed amygdala, was actually noted by a psychologist named Dr. Kluver and a neurosurgeon by the name of Dr. Busey. And I mention Kluver and Busey because in medicine there's actually a syndrome known as Kluver-Busey syndrome. And that's when there's a bilateral destruction of your amygdala. And bilateral means both. When you have bilateral destruction of the amygdalas, that can result in certain symptoms that are often seen, like hyperorality, which means you put things in your mouth a lot. Also, hypersexuality, as well as disinhibited behavior. And disinhibited behavior is when you ignore social conventions, you can act very impulsively, you don't consider the risks of your behavior, so you do dangerous, reckless things. So that's Kluver-Bucy syndrome, and that's, again, when you destroy both sides of your amygdalas. And the way I remember this is I think if you stimulate the amygdalas, that can cause fear and anxiety. And people who have anxiety disorders or experience an anxiety attack, sometimes they're given a medication known as a benzodiazepine. Sometimes they're called benzos. And these benzodiazepine medications function pharmacologically very similar to alcohol. And think of what happens when people consume too much alcohol. Sometimes you see these types of behaviors. You see hyperorality. You might be eating a lot. You might have hypersexuality. And of course, you get disinhibited behavior. Think of the person with a lampshade on their head. They're ignoring certain social conventions because of the effect of alcohol. So that's how I remember the effect of stimulating versus destroying the amygdala. Now this green structure here that you see curving around the thalamus is known as the hippocampus. And the hippocampus plays a key role in forming new memories. What it does is it helps to convert your short-term memory, abbreviated as STM, it helps convert that short-term memory into your long-term memory. And I mention that in this conversation because when you think back in your memories, whether it's short-term memory or long-term memory, these memories can invoke emotions as well. So the hippocampus is an important structure in forming long-term memories. And people with damage to this area, they have difficulty forming new memories. So everything that they experience just basically fades away. Now, what's interesting about this is if your hippocampus is destroyed, while you can't form new memories, you still have your old memories intact. So your long-term memory functions just fine. So that's the hippocampus. Now lastly, this orange structure here, this orange structure is the hypothalamus. And hypo means below. So hypothalamus is below the thalamus. And here's the thalamus, and it's below it. So that's where it gets its name from. And the hypothalamus is actually a very tiny structure. And this diagram here really exaggerates the size of the hypothalamus. The hypothalamus is so small, it actually makes up less than 1% of the total volume of your brain. It's about the size of a kidney bean. And the hypothalamus plays an incredible role in regulating so many functions in your body. But for our purposes, we're talking about the limbic system structures in terms of emotion. So when it comes to emotion, the hypothalamus you can think of as regulating the autonomic nervous system. I'll abbreviate it as ANS. In the autonomic nervous system, you can think of as fight or flight versus rest and digest. Now, I'm going to discuss this further in a different video, but right now just think of it as regulating the autonomic nervous system. And it does this by controlling the endocrine system, by triggering the release of hormones into your bloodstream. And some of these hormones that are triggered to release are things like epinephrine or norepinephrine. And epinephrine is actually very commonly known as adrenaline. So if you ever think of the phrase like a lot of adrenaline pumping through your veins, that's actually being regulated by the hypothalamus. Your hypothalamus is also involved with regulating other basic drives like hunger, thirst, sleep, sex. But in terms of emotion, I think it's most important to note that it regulates the autonomic nervous system, that fight or flight or rest and digest response. So that's the limbic system. And these are the four basic structures: the thalamus, the amygdala, the hippocampus, and the hypothalamus. So these are the basic structures of the limbic system.
A panic attack is the sudden onset of extreme apprehension or fear, usually associated with feelings of impending doom. I feel like I'm going to die. The feelings of terror present during a panic attack are so severe that normal function is suspended. The perceptual field is severely limited, and the misinterpretation of reality may occur. Severe personality disorganization is evident. People experiencing panic attacks may believe that they are going to lose their minds, or that they've already lost their mind, or that they're having a heart attack. The attacks are often accompanied by highly uncomfortable physical symptoms as well. Some of these symptoms a person may experience are palpitations, chest pain, diaphoresis, muscle tension, urinary frequency, hyperventilation, breathing difficulties, nausea, feelings of choking, chills, hot flashes, and gastrointestinal symptoms as well. Typically, panic attacks occur suddenly. They're not necessarily in response to stress. Sometimes they're extremely intense, last a couple minutes, occasionally lasting up to 30 minutes, and then they subside. Panic attacks can happen at any time during the day or can occur while sleeping at night, causing the person to wake up terrified. During the intervals between panic attacks, the person may experience low-level constant anxiousness and anticipatory anxiety. Since many of the symptoms of panic disorder mimic those of heart disease, thyroid problems, breathing disorders, or other illnesses, people with panic disorder often make many visits to the emergency room or doctor's offices convinced that they have a life-threatening issue. At that point, the person needs to be referred to a counselor for potential diagnosis and treatment of an anxiety disorder. The incidence of panic attacks over time may lead to complications such as persistent anxiety, phobic avoidance, depression, alcoholism, or other drug overuse. At times, people with panic disorder may also have agoraphobia. If agoraphobia is present, it is noted as a specifier on the DSM-5 diagnosis. Pharmacological treatments for panic attacks include high-potency benzos such as alprazolam, clonazepam, and lorazepam. Antidepressants such as tricyclics include amitriptyline, nortriptyline, and SSRIs, which include fluoxetine, sertraline, and paroxetine. MAOs, or the monoamine oxidase inhibitors, are reserved for treatment-resistant conditions such as due to the fact of the life-threatening hypertensive crisis if the patient does not follow dietary restrictions. The main concern is tyramine in the food. The utilization of cognitive and behavioral therapy in conjunction with medicines has been effective in treating a lot of people with panic attacks. A phobia is a persistent, intense, irrational fear of a specific object, activity, or situation that leads to a desire for avoidance, or actual avoidance, of the object, activity, or situation. Specific phobias are characterized by the experience of high levels of anxiety or fear in response to specific objects or situations. This could include dogs, spiders, heights, storms, water, blood, closed spaces, tunnels, bridges, and people. Specific phobias are common and usually do not cause much difficulty because people can always plan to avoid the feared objects such as cats or spiders, flying, or heights. However, the fear, anxiety, or avoidance in some cases may cause impairment in social, occupational, or other areas of functioning when faced with the feared object or situation. There are some common phobias listed in Table 11.5. There is no evidence, however, that these disorders are related to biological dysfunction and need medication to be treated. In fact, behavioral therapy seems to be the only effective therapy with specific phobias. Social anxiety disorders, or social phobias, are characterized by severe anxiety or fear provoked by exposure to a social situation or a performance situation, resulting in humiliation or embarrassment. The intense terror in these types of situations is fear of being evaluated or being rejected by others. Fear of public speaking is the most common social phobia. Barbra Streisand, the great Laurence Olivier, Richard Burton, and Kim Basinger are but a few well-known performers who suffered from terrific bouts of performance anxiety when appearing in front of an audience. Social anxiety disorders are believed to be influenced by psychological factors such as the quality of early attachments, the development of appropriate social skills, inadequate experiences interacting with others, and other negative environmental influences. There's also evidence from twin and high-risk studies that suggest a complex genetic transmission of this disorder. There are currently ongoing biological studies to identify specific neurobiological factors associated with anxiety and fear. The beta blocker propranolol reduces the physiological symptoms of anxiety, although not the cognitive or worry aspect. Propranolol is used effectively by many performers or lecturers before appearing on stage to act, conduct, speak, and otherwise make a presentation in front of an audience. More pervasive social anxiety may respond to MAOIs and SSRIs. Cognitive therapy interventions, along with social skills training, are helpful for many people as well. Agoraphobia is an intense, excessive anxiety about or fear of being in places or situations where help might not be available and escape might be either difficult or embarrassing. The feared places or situations are avoided by the individual in an effort to control anxiety. Examples of situations that are commonly avoided by patients with agoraphobia are being alone outside the home, using public transportation, being out in open spaces such as parking lots or the mall, or being in enclosed places like elevators or theaters, or it could be even just being in a crowd. A DSM-5 diagnosis is made when a person experiences fear or anxiety in at least two of the above situations seen in the slide. Avoidance behaviors can be debilitating and life-constricting as well. All too frequently, complications ensue when individuals attempt to decrease anxiety or depression through self-medication with alcohol or drugs. Generalized anxiety disorder is characterized by persistent, excessive, and unrealistic worry about everyday things. People with this disorder, which can also be referred to as the GAD, experience excessive anxiety and worry, often expecting the worst even when there is no apparent reason for concern. They anticipate disaster, and they may overly be concerned about money, health, family, work, or other issues. It is sometimes referred to as the worry disease. A diagnosis of GAD is made when a person finds it is difficult to control worry on more days than not for at least a 6-month period, and if at least 3 of the following symptoms are present. This includes restlessness, fatigue, poor concentration, irritability, muscle tension, and sleep disturbance. Up to 2/3 of people with generalized anxiety disorder have comorbid major depression, and up to 25% present with panic disorder. Self-medication may lead to alcohol and substance use disorder. Constant worries related to GAD leave the limbic system in a perpetual state of alertness. Decision-making is difficult because of the poor concentration and dread of making a mistake. Somatic symptoms are not uncommon and include sweating, nausea, and diarrhea. The best treatments for GAD are psychotherapy, SSRIs, and SNRIs. This includes Buspar and benzodiazepines. In anxiety attributable to medical conditions, the individual's symptoms of panic attacks and anxiety are a direct physiological result of a medical condition. Several examples of medically induced anxiety attacks are available on page 177 in your book. One of the most commonly seen forms is related to COPD and heart failure in medical patients. The feeling of drowning induces fear and stress in the patient, eliciting a panic attack. Obsessive-compulsive disorder, or OCD, is characterized by unreasonable thoughts and fears or obsessions that lead you to do repetitive behaviors or compulsions. It's also possible to have only obsessions or only compulsions and still have OCD. Obsessive-compulsive symptoms are common, but obsessive-compulsive disorders are extremely disabling and painful. OCD is no longer considered uncommon. Obsessions are defined as thoughts, impulses, or images that persist and recur so that they cannot be dismissed from the mind. Obsessions often seem senseless to the individual who experiences them, although they still cause the individual to experience severe anxiety. OCD often centers around themes such as a fear of getting contaminated by germs. To ease contamination fears, the person may compulsively wash their hands until they're sore and chapped. Despite efforts to ignore or get rid of bothersome thoughts, the thoughts or urges keep coming back. This leads to more ritualistic behaviors and a vicious cycle that's characteristic of OCD. Compulsions can include mental acts as well, such as counting, praying, or performing a compulsive act that temporarily reduces high levels of anxiety. In doing this, we are performing a compulsive act that temporarily reduces high levels of anxiety. The primary gain is achieved by compulsive rituals, but because the relief is only temporary, the compulsive act may be repeated many, many times. Although obsessions and compulsions can exist independently of each other, they most often occur together as an obsessive-compulsive disorder. OCD behavior exists along a continuum. Normal individuals may experience mildly obsessive-compulsive behavior. Nearly everyone has experienced having a song playing persistently through their mind despite attempts to push it away. Many people have had nagging doubts as to whether a door is locked or the stove is turned off. These doubts require the person to go back and check the door or the stove. Minor compulsions, such as touching a Lucky Charm, knocking on wood, and making the sign of the cross upon hearing disturbing news, are not harmful to the individual. Mild compulsions, such as timeliness, orderliness, and reliability, are valued traits in selective contents of the Western society. At the more severe end of the continuum are obsessive-compulsive symptoms that typically center on dirtiness, contamination, and germs, and occur with corresponding compulsions such as cleaning and hand washing. A smaller number of these focus on safety issues and engage in repetitive checking rituals. At the most severe levels are persistent thoughts of sexuality, violence, illness, or death. These obsessions or compulsions cause marked distress to the individual. People often feel humiliation and shame regarding those behaviors. The rituals are time-consuming and interfere with normal routine, social activities, and relationships with others. Severe OCD consumes so much of the individual's mental processes that the performance of cognitive tasks may be impaired. Suicide can also be a risk for these individuals, especially in the presence of co-occurring depression.
Ever hear a really good joke about polio? Or made a casual reference to someone having hepatitis? Or maybe teased your buddy by saying he has muscular dystrophy? Of course you have never done that, because you are not a terrible person. You'd never make fun of someone for having a physical illness. But folks make all kinds of offhand remarks about people having mental illnesses and never give it a second thought. How often have you heard a person say that someone's psycho or schizo or bipolar or OCD? I can pretty much guarantee that the people who use those terms had no idea what they actually meant. We've talked about how psychological disorders and the people who have them have often been stigmatized, but at the same time, we tend to minimize those disorders, using them as nicknames for things that people do, think, or say that may not exactly be universal, but are still basically healthy. And we all do it, but only because we don't really understand those conditions. But that's why we're here, because as we go deeper into psychological disorders, we get a clearer understanding of their symptoms, types, causes, and the perspectives that help explain them. And some of the most common disorders have their root in an unpleasant mental state that's familiar to us all: anxiety. It's a part of being human, but for some people it can develop into intense fear and paralyzing dread and ultimately turn into full-fledged anxiety disorder. Defining psychological disorders again: a deviant, distressful, dysfunctional pattern of thoughts, feelings, or behaviors that interferes with the ability to function in a healthy way. So when it comes to anxiety, that definition is the difference between the guy you probably called phobic because he didn't like Space Mountain as much much as you did, and the person who truly can't leave their house for fear of interacting with others. It's the difference between the girl who's teased by her friends as being OCD because she does her laundry every night, and the girl who has to wash her hands so often that they bleed. Starting today, you're gonna understand all those terms you've been using. We commonly equate anxiety with fear, but anxiety disorders aren't just a matter of fear itself. A key component is also what we do to get rid of that fear. Say someone almost drowned as a kid and is now afraid of water. A family picnic at the river may cause that anxiety to bubble up, and to cope, they may stay sequestered in the car, less anxious but probably still unhappy while the rest of the family is having fun. So in clinical terms, anxiety disorders are characterized not only by distressing, persistent anxiety, but also often by the dysfunctional behaviors that reduce that anxiety. At least a fifth of all people will experience a diagnosable anxiety disorder of some kind at some point in their lives. That is a lot of us. So I want to start out with a condition that used to be categorized as an anxiety disorder, but is now considered complex enough to be in a class by itself: obsessive compulsive disorder, or OCD. You probably know that condition is characterized by unwanted repetitive thoughts which become obsessions, which are sometimes accompanied by actions which become compulsions. And it is a great example of a psychological disorder that could use some mental health myth-busting. Being neat and orderly and fastidious does not make you OCD. OCD is a debilitating condition whose sufferers take normal behaviors like washing your hands or double-checking that you turned off the stove and perform them compulsively. And they often use these compulsive, even ritualistic behaviors to relieve intense and unbearable anxiety. So soon they're scrubbing their hands every 5 minutes, or constantly checking the stove, or counting the exact number of steps they take everywhere they go. If you're still unclear about what it means for disorders to be deviant, distressful, and dysfunctional, OCD might help you understand. Because it is hard to keep a job, run a household, sit still, or do much of anything if you feel intensely compelled to run to the kitchen 20 times an hour. And both the thoughts and behaviors associated with OCD are often driven by a fear that is itself obsessive. Like, if you don't go to the kitchen right now, your house will burn down and your child will die, which makes the condition that much more distressing and self-reinforcing. There are treatments that help OCD, including certain kinds of psychotherapy and some psychotropic drugs. But the key here is that it is not a description for your roommate who cleans her bathroom twice a week, or the guy in the cubicle next to you who only likes to use green felt tip pens. And even though OCD is considered its own unique set of psychological issues, the pervasive senses of fear, worry, and loss of control that often accompany it have a lot in common with other anxiety disorders. The broadest of these is generalized anxiety disorder, or GAD. People with this condition tend to feel continually tense and apprehensive, experiencing unfocused, negative, and out-of-control feelings. Of course, feeling this way occasionally is common enough, but feeling it consistently for over 6 months, the length of time required for a formal diagnosis, is not. Folks with GAD worry all the time and are frequently agitated and on edge, but unlike some other kinds of anxiety, patients often can't identify what's causing the anxiousness, so they don't even know what to avoid. Then there's panic disorder, which affects about 1 in 75 people, most often teens and young adults. Its calling card is panic attacks, or sudden episodes of intense dread or sudden fear that come without warning. Unlike the symptoms of GAD, which can be hard to pin down, panic attacks are brief, well-defined, and sometimes severe bouts of elevated anxiety. And if you've ever had one or been with someone who has, you know that they call these attacks for good reason. They can cause chest pains and racing heartbeat, difficulty breathing, and a general sense that you're going crazy or even dying. It's as awful as it sounds. We've talked a lot about the body's physiological fight or flight response, and that's definitely part of what's going on here, even though there often isn't an obvious trigger. There may be a genetic predisposition to panic disorder, but persistent stress or having experienced psychological trauma in the past can also set you up for these attacks. And because the attacks themselves can be downright terrifying, a common trigger for panic disorder is simply the fear of having another panic attack. How's that for a kick in the head? Say you have a panic attack on a bus, so you find yourself hyperventilating in front of dozens of strangers with nowhere to go to calm yourself down. That whole ordeal might make you never want to be in that situation again, so your anxiety could lead you to start avoiding crowded or confined places. At this point, the initial anxiety has spun off into a fear of anxiety, which means, welcome, you've migrated into another realm of anxiety disorder, phobias. And again, this is a term that's been misused for a long time to describe people who say don't like cats or are uncomfortable on long plane trips. Simply experiencing fear or discomfort doesn't make you phobic. In clinical terms, phobias are persistent, irrational fears of specific objects, activities, or situations that also, and this is important, leads to avoidance behavior. You hear a lot about fears of heights or spiders or clowns, and those are real things. They're specific phobias that focus on particular objects or situations. For example, the Chesapeake Bay Bridge in Maryland is a 7,000 meter span that crosses the Chesapeake Bay. If you want to get to or from eastern Maryland, that's pretty much the only way to do it, at least in a car. But there are thousands of people who are so afraid of crossing that bridge that they simply can't do it. So to accommodate this avoidance behavior, driver services are available. For $25, people with gephyrophobia, a fear of bridges, can hire someone to drive themselves and their kids and dogs and groceries across the bridge in their own car while trying not to freak out. But other phobias lack such specific triggers. What we might think of as social phobia, currently known as social anxiety disorder, is characterized by anxiety related to interacting or being seen by others, which could be triggered by a phone call or being called on in class or just thinking about meeting new people. So you can probably see at this point how anxiety disorders are related and how they can be difficult to tease apart. The same thing can be said about what we think causes them. Because much in the same way that anxiety can show up as both a feeling, like panic, and a thought, like, is my kitchen on fire, there are also two main perspectives on how we currently view anxiety, as a function of both learning and biology. The learning perspective suggests that things like conditioning and observational learning and cognition, all of which we've talked about before, best explain the source of our anxiety. Remember our behaviorist friend John B. Watson and his conditioning experiments with poor little Albert? By making a loud, scary noise every time he showed the kid a white rat, he ended up conditioning the boy to fear any furry object, from bunnies to dogs to fur coats. That conditioning used two specific learning processes to cement itself in little Albert's young mind. Stimulus generalization expanded or generalized his fear of the rat to other furry objects. The same principle holds true if you were attacked by your neighbor's mean parrot and subsequently fear all birds. But then the anxiety is solidified through reinforcement. Every time you avoid or escape a feared situation, a pair of fuzzy slippers or a robin on the street, you ease your anxiety, which might make you feel better temporarily, but it actually reinforces your phobic behavior, making it stronger. Cognition also influences our anxiety, whether we interpret a strange noise outside as a hungry bear or a robber or merely the wind determines if we roll over and keep snoring or freak out and run for a kitchen knife. And we might also acquire anxiety from other people through observational learning. A parent who's terrified of water may end up instilling that fear in their child by violently snatching them away from kiddie pools or generally acting anxious around park fountains and duck ponds. But there are also equally important biological perspectives. Natural selection, for instance, might explain why we seem more likely to fear certain potentially dangerous animals like snakes, or why fears of heights or closed-in spaces are relatively common. It's probably true that our more wary ancestors who had the sense to stay away from cliff edges and hissing serpents were more likely to live another day and pass along their genes, so this might explain why those fears can persist, and why even people who live in places without poisonous snakes would still fear snakes anyway. And then you got the genetics and the brain chemistry to consider. Research has shown, for example, that identical twins, those eternal test subjects, are more likely to develop similar phobias even if they're raised apart. Some researchers have detected 17 different genes that seem to be expressed with various anxiety disorders, so it may be that some folks are just naturally more anxious than others, and they might pass on that quality to their kids. And of course, individual brains have a lot to say about how they process anxiety. Physiologically, people who experience panic attacks, generalized anxiety, or obsessive compulsions show over-arousal in the areas of the brain that deal with impulse control and habitual behaviors. Now, we don't know whether these irregularities cause the disorder or caused by it, but again, it reinforces the truism that everything that is psychological is simultaneously biological. And that holds true for many other psychological disorders we'll talk about in the coming weeks, many of which have names that you've also heard being misused in the past. Today, you learned what defines an anxiety disorder as well as the symptoms of obsessive obsessive-compulsive disorder, generalized anxiety disorder, panic disorder, and phobias. You also learned about the two main perspectives on the origins of anxiety disorders, the learning perspective and the biological perspective, and hopefully you learned not to use OCD as a punchline from now on. Thanks for watching, especially to all of our Subbable subscribers who make Crash Course available to them and also to everyone else. To find out how you can become a supporter, just go to subbable.com/crashcourse. This episode was written by Kathleen Yale, edited by Blake DiPastino, and our consultant is Dr. Ranjit Bhagwat. Our director and editor is Nicholas Jenkins. The script supervisor is Michael Ronda, who is also our sound designer, and the graphics team is Thought Cafe.
Hoarding behaviors can begin as early as the teenage years, although the average age of a person seeking treatment for hoarding is around the age of 50. Hoarders often endure a lifelong struggle with hoarding. They tend to live alone and may have a family member with the problem as well. It seems likely that serious hoarding problems are present in at least 1 in 50 people, but they may be present in as many as 1 in 20. Compulsive hoarding was commonly considered to be a type of OCD. Some estimate that as many as 1 in 4 people with OCD have compulsive hoarding. Recent research suggests that nearly 1 in 5 compulsive hoarders have non-hoarding OCD symptoms to follow that. Compulsive hoarding is also considered a feature of obsessive-compulsive personality disorder and may develop along with other mental illnesses, such as dementia, schizophrenia, and many others. Most often, people hoard common possessions such as paper like mail or newspapers, books, clothing, containers, boxes, paper and plastic bags. Some people hoard garbage or rotten food. More rarely, people hoard animals or human waste products. Often, the items collected are of value but far in excess of what can be reasonably used. Severe clutter threatens the health and safety of those living in or near the home, causing health problems, structural damage, fire, and even death. Expensive and emotionally devastating evictions or other court actions can lead to hospitalizations or homelessness. Conflict with family members and friends who are frustrated and concerned about the state of the home in the hoarding behaviors too. People who hoard may call themselves thrifty. They may also think that their behavior is due to having lived through a period of poverty or hardship during their lives. Research to date has not supported this idea, though. However, experiencing a traumatic event or serious loss, such as death of a spouse or parent, may lead to worsening of hoarding behaviors. Among the most useful therapies are cognitive behavioral therapies, which provide education, address cognitive distortions, and present behavioral approaches in an attempt to reduce symptoms and increase involvement with others and the environment. The cognitive element of cognitive behavioral therapies refers to teaching people to restructure their thinking and examine their assumptions, problems, or concerns so that problems or concerns seem more amenable to change and hold less negative emotional impact. Essentially, the therapist helps patients correct their faulty conceptions and helps them change their self-signals or self-talk. Teaching people to successfully redefine their fears and to look at themselves in a new and more positive way can trigger chemical changes in the brain similar to those caused by medications. There are currently several forms of behavioral therapy which involves teaching and physical practice of activities to decrease anxious or avoidant behaviors. As noted earlier, one form of behavioral therapy is relaxation training. Examples which include modeling, which is mimicking appropriate behaviors and situations, systematic desensitization, which is gradually exposing a person to the feared object or situation until the person is free of incapacitating anxiety. There's response prevention. This starts with the therapist preventing the compulsions such as hand washing and gradually helping the patient limit the time between rituals until the urge dissipates. The last one would be thought stopping. Examples include snapping a rubber band on one's wrist to stop an obsession or negative thought. Medications are most useful when used as a co-treatment with other therapies, especially cognitive behavioral therapy. Evidence states that SSRIs alone, or paired with an SNRI, anxiety symptoms are treated much more effectively. Page 186 in your book covers a lot of the medications that are used to treat anxiety disorders. That being said, Prozac, Luvox, Paxil, and Zoloft are not useful with the treatment of social anxiety disorder or panic disorder. Benzodiazepines are only for short-term use. Most atypical benzos suppress rapid eye movement sleep, causing daytime fatigue and impaired concentration. Sonata is an exception and preferable as a hypnotic agent or a sleep aid. The use of BoostBar for treating anxiety disorders has been used for over 30 years. The use in generalized anxiety disorder is still fairly new, but the use of BoostBar seems to be a safer alternative to benzos due to the lesser chance of abuse with this medication.